All right.
Hi, yeah.
Oh, sorry, go ahead.
Oh no, go ahead. Okay, hi everyone. Thank you for coming, joining us for another session of Dental Shadowers. Today, I am hosting this session with Dr. Jessica Chiang, who is a pediatric resident. Um, Whenever you're ready, you can start your presentation.
Thank you so much, Crystal. I appreciate it, and thanks for having me. As Crystal mentioned, I'm Jessica. I'm a pediatric dental resident. During this presentation, if you have any questions, feel free to stop me. And this is going to be like a brief overview of what pediatric dentistry is, and also just kind of my personal journey of how I've gotten here and maybe some of my future goals as well. So this is my journey to pediatric dentistry. It is a great specialty. I really do enjoy it. There's a lot of great kids, and you change a lot of kids' lives and their outlooks when it comes to dentistry. We are part of this overarching board, the American Academy of Pediatric Dentistry. It's called AAPD for short. Now, I'm in California, so if you're in California, it's going to be California Society of Pediatric Dentistry, and every state has their own kind of society. And so for short, that's CSPD. Um, the typical pathway is, college, dental school, residency. I did do a master's in between college and dental school. And I did college, my master's, and my dental school all at the same school, which was UCLA, and then got into UCSF for my residency. I wanted to touch base on the types of residencies you could encounter when it comes to peds, which is the hospital based, and usually this is a paid position. However, the difference is that there might be a little bit heavier on calls, so you'll have like a pager, or you'll have some sort of pager system where if there's any sort of dental emergencies, such as like a tooth falling out, or a kid like hits their face and injures their tooth, then you'll be on call to help kind of alleviate the issue. There's also university based, and this is also like a lot of the pediatric positions as a resident is slowly getting more paid. Obviously, you're not getting paid a lot, but you're getting paid a little bit of something. University based means that there's tuition, so you have to pay a little bit of tuition, and there is some stipend. So that's what I mean by like you still get paid, but it kind of varies by program. And then we also have combined university and hospital. UCSF I would categorize that as a combined program.
Dr. Chiang, I can't see
Yeah.
your screen. The presentation didn't move. Sorry to interrupt.
Oh, no worries. It did not move.
No.
Is it still on my, hold on, sorry. Let's see. Technical difficulties, huh?
Yeah.
Okay, let me share my screen again. And how's this? Better?
Could
Yes.
you hit the next slide and let me see if it moves forward? Yeah, we can see it. Sorry
Okay,
about
sorry
that.
about
Thank
that.
you.
Okay, so this is just what I was just talking about earlier. And then when it comes to activities, um, now I know a lot of y'all are still like pre-dental, and not your whole resume has to be related to dentistry. I didn't realize that until after. So, like, obviously, your academics are important, but that's not the only thing the admissions committee sees. So, if you're interested in music or sports, or you want to travel abroad, I really do encourage you to do this now, because it does get a lot more difficult with time and working and things like that. So, be curious and do what you want, and don't be too worried about the outcome. I think that's like the biggest thing that I wish I took home when I was a pre-dent. And I think one of the keys to success is to build some habits. So, make a schedule, make the lists, but also have fun, like I wouldn't always be at the books, and in fact I wouldn't do that often. But it's good to socialize and learn from other people as much as you can. And when it comes to preparing your application, um, so this is really important. You have to still understand of like what your timeline is. So for example, if you want to make sure that you get into dental school after college, right after, then you should be, I think, ready to go to submit your application by what, the end of your third year? So you're interviewing your fourth year. Yeah, sorry, this is like so long ago for me, so I'm like trying to put myself back in that time. But yes, and then sometimes if you want to take a gap year, that's also valid too. And that's essentially like what I did, and I have no regrets when it comes to a gap year. The gap year can be filled with a master's, and I did a master's mainly because I felt like I had everything else in my application but research. And when I was applying, not saying you need research, but it does help you. These things help you. So I always thought of like a pyramid in a sense. Do I have community service, leadership, and research? So those were kind of like my big three when it comes to extracurricular stuff. And I felt like I was lacking there. So I took some time to look at my application as a whole and be like, okay, something is missing, what is missing? And then I did a master's, but also enjoyed my time with traveling and things like that because you won't get that time otherwise. Any questions so far? No? Okay, I'll move on. So what is it like in pediatric dentistry? It is really fast. Your procedures with kids have really short attention spans. So you're doing fillings, you're doing crowns, hopefully within an hour. And you're seeing multiple patients on top of that. So there's usually 40 patients a day, because as a pediatric dentist, you're managing many columns. Some columns will be just recalls. Okay, that's your and then some are, oops, sorry. Some are just operative, which means your fillings, crowns, extractions, what have you. Okay. There is something so beautiful about pediatric dentistry where you get to develop a relationship and grow with the child. So you get to see, I get to see a lot of children who come through the office scared, and they either go through myself or my other residents and faculty, and you really see their confidence build. And dentistry for kids, it's like learning how to play the piano the first time. So you have to help guide these kids and build their confidence. And once you build their confidence and you kind of be transparent with what you're doing and they understand as well, it's going to be a knock in the park, like a ballpark and things like that. So it's going to be really easy once they kind of know what's going on. But not only are you managing the kid, you're also managing the parent. So the parent also should be always well versed of what you're doing. So, there's different types of parenting styles, there's different types of parents. So you're gonna walk in as the provider and be able to learn how to quickly assess, okay, what kind of parent am I working with today, and what kind of kid am I working with today? A lot of kids are anxious, but they don't know how to voice that. But you'll be able to see like, oh, this kid is very scared about certain things, and be able to modify or do a lot of behavioral guidance, which is really big in pediatric dentistry. So, you have to be quick with decision making and be very kind of more street smart when it comes to treating the kid. So what kind of things do patients present with? These are just a small fraction of what the kids come in with. These right here on this left picture here, the behind teeth are permanent teeth, and the front are the baby teeth. And what essentially has happened is that the baby teeth have they have not exfoliated yet. They're a little late, and so the permanent teeth, because they have no room, they'll grow behind. This isn't like a huge concern or a big emergency, but a lot of parents get concerned with that, right? So usually we just, suggest like, oh, this is something that we could monitor, and your homework is to wiggle at home. And that's not a big deal. However, the one picture on the right here, this is called a crown fracture with pulp exposure or pulp involvement. You could see this little like red blushing over here, which means that the nerve in the blood supply has been affected in this case of trauma that this kiddo experienced. And so something like this usually requires some sort of like partial root canal that the pediatric dentist could do. And you do a lot of like behavioral management, not only with the kid, but with the parent, with kind of explaining to them the expectations of what to come with this tooth. So something like this may or may not need a root canal in the future, and may or may not need a crown, a custom crown that to help kind of restore this tooth. But as a pediatric dentist, our job is to help maintain this tooth as best as we can until this child is old enough to get like the root canal or the crown needed. This is also a bigger trauma here, where sometimes kids fall, and kids fall so often because they're learning how to walk, ages 1 to 3, and then they start to go to school and go into the playground. And so when they go to the playground and play with their friends, they hit their head. And so this is something that's, I would say, we don't see super often, but something we do have to understand how to manage. Now, things, what that means is also understanding when to refer. So refer to other specialists. For example, I mentioned about a root canal. We don't do the root canal as pediatric dentists. The endodontist, who specializes in like doing the root canals, may be able to do that for us. Okay, something like this on the face, that's probably more in the realm of plastic surgery to help make sure that the sutures are done nicely, and so that the healing is done correctly as well. Everyone good so far? Yes. All right. This is another big problem we see in pediatric dentistry. This is called an abscess. Okay, so when a cavity is getting too big and, hygiene's neglected and everything, it can lead to this, where there's like almost like a fluid-based infection. And typically this is really painful, like not it gets painful leading up to this point. And then obviously for a tooth like this on baby teeth, our plan is to extract, right? So because the infection has spread too quickly. If this is not treated, this can also affect systemically. So that's why it's really important to make sure that we are treating this. Before we do extraction, sometimes some providers will elect to prescribe some antibiotics to help with the swelling, and before the procedure is actually done. It will be less painful if we do antibiotics before the extraction. So I wanted to show you like what can kids present with when it comes to cavities, and it's a spectrum. So you see on the left hand side wide spots, that's really early signs of cavities. So any sort of chalkiness, I know this picture's not the greatest, but a little bit of chalkiness may suggest like, okay, like these teeth will develop cavities. Now in the middle, this yellow soft substance means that the cavity has penetrated the layers a little bit more. In a tooth itself, there's, I call it 3 layers of the tooth. So enamel is the outermost part, then we reach into dentin, and then the most severe is the pulp nerve supply. Now this has not reached pulp nerve supply just yet, but this is into dentin, and if untreated, it can lead to pulp exposure and pulpal involvement, similar to what we saw in the last slide with the kiddo who fell and hit their tooth. This is something I see a lot in the clinic. Advanced early childhood caries is what ECC stands for. And what this is typically a lot of these kiddos present with milk bottle decay. So that means that they're sleeping with the milk and they're eating regular foods. No one's brushing their teeth, or not educated to brush their teeth. And so it can lead to this, where the maxillary teeth incisors are affected the most. Now, does anyone have any idea why they think the maxillary incisors are affected more than the bottom one? No, it's okay. It's kind of a tricky question. So we have saliva, which pools on the bottom of our mouth, and the saliva is a protective factor. So that's why when it comes to a kid eating or drinking milk, that's why the top teeth are mostly affected, because we luckily have saliva as a protective factor. It kind of washes things out better than the top teeth. Okay. And this is just a kid. This is a really common thing where, we have a young kiddo here, and a lot of these kids, it's their first dental visit, and they're afraid of basic things that you and I would consider basic, like sitting in the chair, looking, having someone look in our mouth with a mirror. But this kid is not having the best time. So this is called a knee-to-knee exam. We do this for kids up to age 3, usually. We help them get acclimated to first coming to the dentist first before they sit in the chair. But if they sit in the chair, great. But some kids aren't like that. So they'll sit in the parent's lap, and then the head is lowered into the provider's lap. And then when they cry is our chance to kind of take a good look into the mouth. So what kind of procedures do pediatric dentists perform? We perform like a good number of stuff. This is a good example where we have cavities before, and then look at these beautiful like crowns, interior crowns that are placed. So we typically try to do white crowns in the front, and then this is called a stainless steel crown, an SSC for short. And this is one of the most protective restorations we can offer for the back teeth. Sometimes there are zirconia crowns where there are white posterior crowns, but there's a lot of advantages and disadvantages with that comes with it, but I won't bore you with the details with that. But just know that there are a lot of options here. We do extractions, and then this is a nitrous nose that we help put on kids to reduce anxiety. And then not pictured here, but we also do ortho. So orthodontics, some phase 1 orthodontics. And I think I have a case to highlight some of that later on. This is called, I think this kiddo is being under general anesthesia. So usually general anesthesia is when a kid is put completely to sleep. And then we have anesthesiologists with us, and then the dental team to help see this kid, because either they have some sort of complex medical condition or a complex behavioral condition that does not allow for treatment in the chair. So that's one of the most advanced behavioral techniques, I would say. Using the nitrous is a basic behavioral guidance. That's in the dental office. And then in the middle is something called sedation, where a kid could drink some oral medicine, and they get a little less anxious and a little less stress about the appointment. But these sedation appointments are really important in terms of case selection, where we have to make sure their airway is clear beforehand. We have to make sure their medical history is all clear. And most importantly, if they're even able to take the medication by mouth. Some kids refuse to take Benadryl. And if they can't take Benadryl, they're not a candidate for sedation. So a lot of things to consider when it comes to pediatric dentistry. These are just more examples. I want to show you this radiograph of this like really big cavity here. So this gray part here, these are all cavities here, and the silver part here, they're silver fillings, and then I don't know what's going on here, but something bad is happening. It's an infection of some sort. So these are some problems to watch out for children early on. So spacing is not a horrible thing. And a lot of kids come in with a lot of spacing. So the spacing allows for a lot of food to be flushed out, and it's when the teeth are really close that gets a little more difficult, and then you'll see these cavities that start to form in between the teeth. We have something called an open bite. When someone bites on their back teeth, their front teeth are still open. We have a deep bite where the top teeth cover the bottom teeth completely. A cross bite is when the bottom front teeth are over the top teeth. And normally it's like this. Our top teeth are over our bottom teeth, but then a crossbite is reversed. And that goes the same thing on the back. So if you can imagine that this is the back teeth, and then this is the top, this is the bottom, this is a normal one where the top overlaps the bottom a little bit. But then if it's the opposite, it's also what we call a posterior crossbite. So some things to note there. And then underbite is similar to basically a crossbite. It's like the same thing, but just more generalized with more teeth. Overjet, I want to highlight overjet is a horizontal measurement. So we're looking at the distance horizontally between the edge of the maxillary incisor to the edge of the mandibular incisor, versus overbite, we're talking about a vertical dimension here. Okay, so the vertical dimension meaning like, oh, does this kid have a deep bite or, a normal bite? You see right here, this is more vertical here. Then sometimes we have abnormal eruptions. Occasionally this is called ectopic eruptions, where the teeth are not, they're erupting in a different location than they need to. And so sometimes this is really common because there's not enough room for the adult tooth to come in. These are some equipment that we use here. So, these are some extraction forceps. These are for the back teeth. Sometimes there's forceps specifically for the anterior teeth. I personally have not used this, but it looks way more comfortable than what I've been using, which is my own lap and the parents' lap. So this is really nice. And then these are called zirconia crowns. These are probably the most aesthetic thing that we could offer for a kid. I mean, they look like regular normal teeth. And then stainless crowns are in the back here. And then this is what I was talking about, though not a great picture, are like the back teeth, posterior zirconia crowns, which is great aesthetically, but when you're prepping them as a pediatric dentist, you'll notice that you need to do much more reduction on a zirconia crown than a stainless steel crown. And sometimes that may or may not lead to some pulpal sensitivity or involvement. So just things to consider to kind of educate the parent on as well. And it is more prone to fractures because zirconia, is, ceramic in a sense, and it's not like stainless steel, so it can't chip off. This is a medicament that is commonly used in pediatric dentistry. It's called silver diamine fluoride, SDF for short. This SDF is used to arrest caries progression. So here we have caries on, also, by the way, when we talk about pediatric dentistry, we have a different numeric system. So typically normal adult teeth is like 1 through 16, but then we, for pediatrics, we go A through J on the top, K through T on the bottom. So here we have some caries. Like you could start to even see it on D through G, but mostly affected from E, F, and G. So what they did here was they put SDF, it's a brush application, and we always inform the parents that this will turn black forever until the tooth falls out or until the tooth is restored, because no parent wants to not know that their kid's teeth is going to be stained black forever. So you have to make sure you tell the parent about this risk, though it's an aesthetic risk. So this is best applied 2 times a year. If you apply it once, that's fine. But I mean, you always also tell the parent, like, this can always progress into something a little more worse, but at least it's something, it's like a treatment for a lot of the cases where either we see cavities are really small in the beginning, or because we can't render treatment for that kid at this time. Everyone good so far? Okay. I use these terms a lot. We have basic dental terminology, X-ray, explore, mouth mirror. So when it comes to explore, it's my tooth counter. I'm just counting. If I'm using nitrous oxide, I call it my ice cream nose. We usually put like a scent in. And then like cavities or like sugar bugs. Oh, do you want sugar bugs to be eating in your mouth? Things like that to help make the appointment a little easier for the kids and for them to cope in the dental setting. So I have like 2 cases. These are really basic pediatric dental cases. And I'll just kind of briefly go over them. So 5-year-old shows up as a walk-in emergency. Mom says he's complaining of pain on the back left teeth. And the kid is afraid of coming into the room. Child says nothing hurts, and sometimes they do say that. Though mom was saying he was complaining about the back tooth just yesterday. So you start to do the exam, but patient's too nervous for exam. So what do? So this is really common in pediatric dentistry. So a lot of the things that we do is a lot of tell, show, do, TSD for short. Okay. A lot of the kids, assuming that they're medically and behaviorally, like, nothing's changed in a sense, you could easily like teach them what a mirror is, what an explorer is, and kind of ease their way through. Kids also just need a lot of like patience. So kind of telling them what you're going to do and we're just counting or we're just brushing is a great way to build trust before you do treatment. Okay. Sometimes kids throughout, let's say they need like, oh, by the way, we do quadrants of dentistry in pediatrics. So let's say a kid is planned for all 4 quads of dentistry, then and they're doing it in the dental office, a lot of times the behavior starts to decline and after the first appointment. And why might that be? Why wouldn't you think that like a kid who's gone through like 2-3 appointments of dental procedures be good? Right? The reason why is because they're smart. These kids are smart. They know what to expect just as much as like we do. So the more they come for dental procedures, the more they're like, all right, I'm getting the sleepy juice again, and I don't want that. So I'm going to make a whole fuss about it. So they do that all the time. So in this case, a lot of tell, show, do is what I would do. And usually I'm able to reason with the kid. And then show them what an x-ray is and need to take an x-ray to see the extent of the infection. And then kind of think quickly on my feet about, okay, does this kid have just that tooth that's bothering him? Are there other teeth that need work as well? And then how do we get this done for this kid? Either it's dental, office, sedation, or GA, or the different modalities. Okay. And then this is what I was talking about for the case 1. So this is the left side, and you could see, look at this really large cavity here, right? This cavity here is tooth L and K, but L is worse because it's approximating the pulp here. And then this one is interdentin. Okay, so that's the radiolucency, and we even have caries up here too, but I digress. Anywho, so usually for something like tooth L where caries is close to the pulp, we'll try to do a partial root canal. It's called a pulpotomy, where we removed just this top portion of the pulp and not do the roots. If we do the roots, the procedure is called a pulpectomy. Okay, so this is just the top portion. So we remove and clean this portion out. And then we put some medicament. Usually it's for our clinic, we've been using MTA. And that's a material that helps with rebuilding some of the second layer, the dentin part of the tooth. So we put the medicament on, and then we like put the crown on top as well. So that's what we would do there. Yep. So this is called a pulpotomy. So these are the steps where we see a little bit of bleeding, right? We wait for the bleeding to stop completely. And then we usually put some sort of medicament on. It could be, and you'll learn more about this in dental school, so I'm not going to bore you with the medication, the pharmacology that comes with it. But you'll put medicament on and put a crown on. And here it is post-operatively. So they elected to do a silver filling here, which is fine, but sometimes you could do a composite too, or a white filling. Some will also elect for a crown. It's really up to the patient population, the patient, and things like that. But this is what we would do for a case like this. For our second case, we noticed that this kid has, what is this called? We talked about this. Does anyone know? It's called an open bite. So this is really common in kids who suck their thumb past age 3. So if a kid is using a pacifier and stops at like age 2.5 and things like that, that's fine. But it's usually kiddos who are like still 7 years old and sucking their teeth. It's because the bone is so like forgiving or changing so quickly. So with this kind of intervention, the mouth will adapt to the habit. And that's what's happened here. Okay. So when we have kids come in, like, and we notice that, oh, they might be sucking their thumb, or we see this early on, we tell the parents like right away to see if they could do some early intervention and make sure that the kid stops. There are appliances that can be fabricated and given to the patient to help stop this. So this is called a palatal tongue crib. I've seen this more often than the bluegrass appliance, but the palatal tongue crib is an appliance that's custom made. So you'll need to make an impression and things like that, have bands fitted as you see on these baby teeth. And what this is kind of like preventing the kid from putting their thumb into their mouth. And we do this until the parent reports that the habit has stopped completely. Okay. So sometimes if there is no appliance, like I've advised parents to also just put like vinegar on their thumb, something really bad tasting, so that when they put their thumb in, they'll be like, oh, this is not a good taste. So this is a kid. This is another example, but this kid has braces on, just 4 braces. Something like this is what I mean by the orthodontic work that pediatric dentists can do and intervene. So we have phase 1 and phase 2. Phase 1 is to correct some of the early problems we see, so that when it comes to phase 2, it's an easier transition. Because some kids, like, their mouth is so forgiving. If we do changes now, it'll be way easier for them versus waiting until they're a little more grown. Sometimes it's a little more difficult to do these orthodontic cases for the orthodontist, because there's their bone isn't that forgiving, or their sutures aren't that forgiving, so it's harder to change. And so this is just like the kind of impact you could give on a kid, identifying these problems early and being able to correct habits and make appropriate referrals can lead to a result like this. And is it perfect? No, but it's again allowing for an easier transition when the kid needs to go to phase 2. So, I know y'all are in the process of getting ready for dental school, and what I was talking about is so nuanced. It's so my advice is rock the DAT. Don't spoil the practice test on DAT boot camp as like a way to be like, oh, let me see what the questions are. Save all of this to the end. Do the DAT destroyer, like that will destroy you. And then prepare the application with you know, making lists and asking your letter writers ahead of time. And reminders are good. Sometimes these letter writers, they forget, and so you just got to be on top of that. And I think it's still rolling admissions, right? So earlier the better, so that you can get an earlier interview, because once those spots are filled, they're filled unless someone's drops essentially. So that is my biggest advice, is to, work hard, have fun, but plan. And I believe that's about it. And I think there's some questions that Crystal.
Yes, there are, yeah. So thank you, Dr. Chiang, for your presentation. We're just gonna move on to the Q&A session. I did have a lot of questions come in the chat, so we'll start with
Okay,
those.
sounds good.
Okay. The first question that I got was, what was your greatest challenge during dental school?
Oh my gosh, there were so many. I think one of the biggest, because you're learning all the specialties and all the basics of dentistry. And I went to UCLA, and UCLA was known for really hard didactics, and that's what killed me. And also you're like, so one of the classes I know for sure was prosthodontics, and that dealt with a lot of dentures. And I was like, what is happening? I didn't have a habit. I didn't have a good study habit. So that also ruined me too. Like, I was just like, oh my gosh, like there's a lot of slides that you need to memorize in a short amount of time. So really like creating a habit and a system and how you absorb information, not how others absorb information. So let's say like, and make it efficient too. So if you're drawing out every single thing out of a textbook just so you could absorb it, that's great for your learning, but it won't be sustainable in dental school because there's so many things to memorize, unfortunately. So trying different techniques is my biggest advice when it comes to studying. But yeah, the didactics was like the hardest part.
The next question is, how did you decide on a specialty?
That's a good question too. In dental school, throw yourself at every single specialty. And when you go into dental school, have an open mind, because that's kind of like what I did. I shadowed at different specialties, and I was like, okay, I'm this person. Do I see myself doing this every single day? And I talked to faculty, I talked to my peers, and eventually I was like, okay, what I like about pediatric dentistry was that it was general dentistry, it was peds, and it was ortho, all mixed into one. I have to admit, the dentistry part of pediatric dentistry is probably the easiest thing. It's all about behavioral management when it comes to peds. So that's the most challenging part. But other than that, like I shadowed a lot, and my own pediatric dentist like inspired me to do peds. But go into school with an open mind, and you might surprise yourself into liking something else.
The next question is, do you start working to fix these problems as soon as possible or just watch how it continues?
Um,
Specifically problems like an overbite or an underbite.
yeah, it's a case by case situation. So if something, for example, if I see our front, like these are our front teeth, 8 and 9. If 8 and 9, if 8 is erupted but 9 is not, that signals in my brain like something is wrong. Okay, they should usually come down at the same time or similar times. So if that is the case, then I will take an image, and in the image sometimes I will see something called a mesiodens, or like an extra tooth that's blocking the eruption of one of the teeth. And then at that time I'm like, okay, if it's blocking the pathway of like a permanent tooth, then I would need to intervene pretty fast, because it will never come down on its own if something is blocking its path. Now, if it's something like a deep over bite, sometimes the parent is like really adamant in getting it fixed, but those are things that I'm not super pressed on. I'm more concerned about cavities. I'm concerned about like teeth being blocked, or if there's any sort of oral pathology. I'm concerned about those things. Now, another case was like the earlier I said the over retained teeth and the teeth were growing behind. That's not urgent for me, because I know like that's just slower in the baby teeth exfoliating. So I just always tell the parent, like, I know it's now, but later it will be better.
For the example that you showed us for the stainless steel crown, what happens after the child gets older, like with the stainless steel crown?
Yeah. And that's a question I get a lot from parents. So this crown stays on until the tooth falls out. And each tooth falls out at a different age. So when you're a pediatric dentist, you have to be well versed about when these teeth are supposed to fall out too. It's part of growth and development. So something like this, like let's say this is tooth L, they usually fall out around like age 9 or 10. And it's a range though, because everyone's different, by the way. But like these back teeth, they're way later than the front teeth. So that's why saving them for space for the adult teeth becomes more critical.
At what age should babies start using toothpaste, and which brands do you recommend, and should it contain fluoride?
It should always contain fluoride. Big proponent of fluoride toothpaste. Babies can use toothpaste, but it's the amount that's different. So I didn't include it in here, but up to age 3, we recommend a smear layer. So what that means is if this is a toothbrush, you just smear a little bit on, versus after age 3, it's like a pea-sized amount. Okay, so it's like think of a pea. That's all the amount that you really need. And then sometimes if the baby doesn't let you brush, like, or if it's really difficult for the parent, I've always recommended using like a wet gauze to wipe both sides of the teeth, because they only have like 2 teeth at that time.
When you were applying for a dental school, what did you look for in that specific dental school?
Uh, That's a good question. I usually look for, well, I'm a big like locations person, so I really wanted to stay in California, though I know that's not feasible all the time, but location, the tuition cost also, so and also the if they have opportunities for you to explore specialties, some schools like don't really allow for that, or they're totally separate clinics, if that makes any sense. So it's harder for a pre-doctoral student to get like experience with that specialty. And also I was looking at really the amount of faculty to student ratio. That I think that's huge because you don't want one faculty to 20 people. That would, you would always have to just be waiting for the faculty to be available. So I think understanding that is really big.
How do you balance work and social life?
Mm, I do a multitude of stuff because I'm interested in so many things. I've recently picked up pickleball, so that's really fun. Um, and so in dental school, I don't think I did the best job balancing because what was class after it was lab, and then what was lab, it was studying. And that was really difficult because I felt like there was always a test to come by. But it is good to kind of be like, okay, if I reach this amount of slides, then I'm going to reward myself with this and make these goals for yourself and make those lists. Because I am a list person and it feels really good checking those off. But at the same time, like, dental school was really the only time that I hung out with my dental school classmates every single day until we graduated and then we all moved to different places and I can't see them every day. So that's like a time to cherish. Um, but now that I'm in residency, it's a little different because my program, we do have call, but it's for first and second years, and I'm a third year, so that's kind of like been in like we're done with that. So being done at 5 also was really good because I didn't need to study that much anymore, and so that was really good in terms of balance. But it was really difficult in terms of dental school. So make those goals for yourself when it comes to studying so that you can enjoy the little things around your dental school.
Next question is, what motivates you to go into work and work on patients every day?
Ooh, that's such a good question. What motivates me? I have to say, like, I'm really blessed. I go to a program where my attendings are good. Especially my co-residents. Oh my gosh, my co-residents, they are so amazing. And they are the people I see every day more than my family at this point. And they're so funny, they're so nice, and it makes the environment really fun. And I see the kids, and man, the kids are funny too. Like they say some funny stuff and I'm like, "Oh my gosh." It is really cool cuz these kids are different from how we grew up. They have the information at their fingertips. So they also learn way faster.
Next question is, do you recommend doing a post-bac or a master's program before going into dental school?
I would say I would recommend it if you think you need it. Um, but what I recommend personally, knowing that I went through a master's, I like the master's because at the end of the day, you're getting a diploma. I think that's what made me stand out. And that's something that I could like frame and be proud of in a sense. Not to say that like when you do a post-bac, you're not proud of that too. It's just that I don't you don't get the same diploma as a master's, but like it yes, the work is different, but I've also seen people who have done the post-bacs and just done phenomenal, like truly phenomenal. So it's kind of up to you and like what your circumstances allow for. So, if a program is available to you, whether that's a post-bac or master's, I think that's wonderful. And I think if everything is a green light, then definitely go ahead and pursue it.
Next question is, what sparked your interest in dentistry?
So my own pediatric dentist, he was the one who treated me and I have a younger brother, so me and my brother, and we moved around for so many times when we were younger that we didn't have like this established dental home until we met him, and he was the nicest guy ever. So, and the most patient. So I was like, okay, I every time I saw him, I saw myself in him, and I was like, I think I could do this like every day. And then I explored it a little bit more. I was actually into pre-med first, and I was like, okay, let me do this. But then I was like, I can't do pre-med. Like, I can't be in the hospital. It's like too sad for me. And I did a program called Care Extenders at UCLA, and all I did was like answer the nurses' phones, and I was like, I can't do this. And so I was like, okay, what can I do really? Because I still want to be in the healthcare field. And so I shadowed my doctor a lot, my dentist, and then um it just kind of clicked, and I was like, okay, I think I'm gonna try to do this. And that's how I got into dentistry.
The next one is a two-part question. First one is what has been the most challenging with pediatric dentistry versus adult general dentistry, and what is the most rewarding part of pediatric dentistry?
I'll start with the most difficult. So the difficult part are the parents. So the parents come in with a lot of expectations, and a lot of pediatric dentistry is not just managing the kid, but managing the parents' expectations. So you're trying to put down like two fires at once, in a sense. Um, versus, and also it takes a lot of time in pediatric dentistry for a fearful kid versus a adult who is just going to be there and open their mouth. Now, what I like about pediatric dentistry and what's most rewarding about it is the change in behavior over time with these kids, and really the impact you make on these kids. I see kids in pain, but then they come see us and they're like brave kiddos. We do the procedure and they're out of pain. Like, that's great, and um changing their outlook on dentistry, and sometimes even when they are like, "Oh, I want to be a dentist too." And I'm like, "Oh my gosh, like that's so cute." That's really rewarding to hear. So that's the best part, really. The kids. They're really awesome. Even like if they're difficult, you understand why. Like, I'm a stranger to them and I'm trying to do something in their mouth. But like you just kind of like talk to them and try to reason with them, and it's a fun specialty.
The next question is, if we do a post-bac or a master's, what should we do it in, and does it stand out in dental school?
That's a great question. Will it stand out in dental school? Yes. Anything you do post dental school, like the residencies, I'm sorry, post college before dental school, right?
Yeah, like a
Yeah.
post-bac or a master's.
Yeah, sorry. Okay. Anything you do after post college is like super interesting for programs to see. They'll be interested in all of it. They'll be like, okay, why did you go to Italy? And why did you do this? Tell me about X, Y, and Z. So it is valuable, yes. Now, what to do your post back in? Now, I can't tell you what to do exactly because I'm not too sure myself, but it's something I think I want to say it has to be related to science, right? Because usually, from what I remember, there's like a science GPA and an overall GPA. And if you're doing a post back, I assume you want to bump up your science one. So showing your capabilities that you can do the science stuff will help a lot. Now, does it matter what specific science thing? I don't think it matters as long as you're taking like a load of science classes. I think that's what matters the most.
Next question is, have you had any experience with kids with special needs in pediatric pediatric dentistry, and what was that experience like?
Oh my gosh. This is a big boo-boo on my part. As a pediatric, dental resident, that's all we see also is special needs. Like I forgot to mention that from the get-go. We see a lot of special needs kids. I've learned a lot of like syndromes and medical conditions through this residency, and every special needs kid is different, and your approach to dentistry is different. So it's also something really rewarding to see and to do for these kids. I've seen kids who are like really scared of entering the dental room to being so comfortable to like sit in the dental chair, and that's huge for them because they never do, or they had a history of not sitting in the chair, so that's really important.
I think that's the last question I got. Let me see. Yeah, but I'll wait another minute to see if anybody has any other last minute questions, and then we'll wrap up the session if nobody has any more questions.
Okay.
I'll just wait a little bit, like a minute.
But you guys had a lot of great questions, so I hope I provided like some good intel about pediatric dentistry, and I hope I inspired y'all to become pediatric dentists. I am biased though, If you were to tell me that I had to go back to general dentistry, I can't do it. I really cannot. Yeah.
Was it just the environment that made you feel that way, or like just
It's the procedures. Like when you're doing general dentistry, you're the dentist in general for all these procedures. Now, whether you got exposure to that in dental school is a different story, but like, I don't know. With the kids' teeth, they're more forgiving. I make a crown, it falls off like at around different ages versus an adult. If I make a crown, it doesn't feel right, I have to adjust it, remake it, what have you. There's like a lot of stuff. So not to say being a general dentist is bad. I think it's great. For me, it's being a pediatric dentist is a lot easier.
so the question did come up. So are adults worse than kids, or is it more about the procedures?
The adults sometimes can be. I mean, kids, if they cry, you're like, okay, I understand why you're crying. Like, I don't know. I just have a lot more patience with kids than I do with adults. That's just me personally. So I like kids more than adults.
I think those are the last questions, but we will wrap up the Q&A session. But thank you again, Dr. Chiang, for holding the session with our platform, Dental Shadowers. If can you go back to your last slide with your Instagram?
Yeah.
And yeah. So if you want to give Dr. Chiang a follow on Instagram, TikTok, and her email address is also there, available for you if you want to reach out or anything. But I'd like to thank Dr. Chiang once more for joining us on this platform. And thank you to everyone who joined us live through the session. There will be an attendance quiz. It will be posted shortly once I do make it, and it'll be available on our Instagram bio through a link tree. If anybody else has any other questions, you can stay back and I guess I ask. But have a good night. Thank you, Dr.
Thanks,
Chiang.
everyone. Of course.
Thank you.
Thanks.
Thank you.